We are pleased today to have Dr. Daniel Berger from the IAEA, the International Atomic Energy Agency. Dr. Daniel Berger works as a technical officer of Asia Pacific countries related to radiotherapy services in the Division of Human Health in the Department of Nuclear Applications. Of course, Dr. Daniel Berger is known for his great contribution and work in the field of brachytherapy. He was one of the developer of the Vienna applicator that most of the people know it is used, and it was used for years for the brachytherapy applications, especially in the cervical cancer. Welcome, Dr. Daniel. Dr. Daniel, we're pleased to have you. Welcome.
Thank you, Dr. Shaika. It's always a pleasure to be surrounded by so wonderful people, and actually it's the first time that I'm in Kuwait here, and I didn't even plan to have the trip here, but luckily like MEFOM was contacting the agency for this conference to nominate a co-host, and then my name came up, and coincidentally there's also like a big brachy project going on in Kuwait, so I'm more than happy to be here with you guys. Thanks.
We are happy to have you, and we just want to ask you about your beginnings, as we ask everyone. So how did you choose the field of medical physics? How did you end up as a clinical medical physicist? And then how did you make the jump to the IAEA?
Well, that's a good question, because I still have no clue how I ended up in medical physics. Yeah, because at the time when I studied, I went to the university, I still remember that I was very interested in mathematics, and then I had a booklet of the university, and I like technical stuff, like really like doing innovation stuff. And then I had a look, and there was mathematics and technical physics. And then I was reading, as a mathematician, you will go into either finances or you will go into programming, and I really hate code typing. I mean, nowadays with ChatGPT it's easier. I would probably consider code typing now, but at this time, it was really like hard work doing code typing. So I said, no way for me. So I went to the next topic, which was physics. And I said, okay, physics is a very generous topic, and you can work any field. So, okay, I went to technical physics. So I studied technical theoretical physics at the Technical University of Vienna. And at this time, it was like a 8-year program.
Oh, wow.
So it was really tough, and so I managed going through this. I always had an interest in the medical field, and just by coincidence, I did one of my diploma works at the AKH, like the General Hospital of Vienna, where then I actually never left. So when I started there, I did my first moves in the field of medical, and I was very interested in medicine. So that's actually made me studying at the medical university. So I did my PhD at the medical university, and at this time also the profession wasn't recognized. So we called it like grandfather model. So like those who were compiling their knowledge, like from medicine and from physics, we could feel like a curriculum, and then we could apply for this profession. And that's why I became then the medical physicist in a hospital. And the career went on, so I started to be very interested, as I said, like in the medical field. And brachytherapy, you work very close to the patients.
Yes.
Yeah. So that's how I really love to develop applicators, improving the implants, because that was always a challenge to improve the applicators.
Of course. So what was the brachytherapy like when you started in that time?
At that time,
you have to go back in history.
Yeah, I know. At that time, of course, we had actually a very visionary head of the department, Professor Richard Berger, who was the pioneers of image-guided brachytherapy, and he had the choice actually to buy a all-in-one integrated brachy system. There was a brachy suite, or using the funds to buy a cheap open MRI. It was basically a little bit more expensive, but kind of same price. So he just bought an open MRI for the brachytherapy because he loved imaging. He came from radiological backgrounds. And then at the beginning, we did everything on a good old Plato system, it was called at this time, like a silicon graphics workstation, where we had to even digitize the implant. So everything was done on radiographs. But we had a model, like we could acquire MRI images,
Yes.
and then writing the dose grid like generated from the X-rays from digitization. So the dose grid was based on radiographs, yeah? And we were calculating, like computing the dose grid, the volume, yeah? And superimpose this to the MRI.
Oh, wow.
So this was the first step. So really like a step and shoot kind of. Yeah? We were planning on the radiographs and then we were analyzing on the MRI.
So was it like a manual registration?
It was everything manually, everything manually. Exactly. And then it went on. So we also experimented with the applicators, and of course a freehand implant is always difficult, especially when you digitize. And at this time with the radiographs it was even more challenging. AP films are okay, but all the lateral fields going through the hips, always get problematic views and reconstructions. So that's why we came up with a template. Because we know, like, especially the US people, they had these Muppet templates, in the perineum, going with parallel, and it also takes some experience in order to get parallel implants. Yeah? So if you see the old implants, they were like totally skewed and not nice. So we said, okay, we need to move the template closer to the target. Yeah?
Yes.
It's like throwing a dart to the target. If you go very close, you will hit easier than if you're from the distance. So the same concept we had in mind with the Vienna applicator.
Yes.
It was the first. So we were drilling holes into the standard applicator, so closer to the target, and then we were inserting needles there in a very nice geometric pattern.
Did you find actually introducing new technology or new ideas in the field of medical physics, especially brachytherapy? A lot of people, when they work in the hospitals, they're mostly used and to a certain ways, and they're comfortable in their own ways. So when you come with an idea like the Vienna applicator, did you find struggle to introduce it and to convince people that this might be a good idea?
That's always challenging, and this again depends on your management, on your leadership, how open they are to innovations.
Yes.
But it's not only let's say a motivation. It's also a little bit nowadays a little bit the legal aspect, because that's if you develop something new, you need FDA clearance, you need to have a medical product. So it's getting very complicated now to be innovative, because in the time when I was dealing with brachytherapy, it was just a manual skill.
Yes.
Even the applicators were manufactured by our own small workshop. I also I worked a little bit in France, in Paris at the IGR, where they did the famous mold, so the very really cryotherapy where it comes from.
Yes.
So they have really, it's an art of creating applicators, and that's how we combined the purely individualized applicator with a little more standardized way. Yeah? So it's both ways. You need a good leadership who is open for innovation, making change, and also you have to find a way that it's legally okay to do.
Yes, great. And how did you make the move to the IAEA after all these years working brachytherapy, working as a clinical medical physicist, and we can see the passion, So
yeah, the move to the agency was again coincident, because after being on the other side, like as an expert in the field, I was sent some people from the agency to missions, helping the people not only with, let's say, publications, also with like doing it in the field. And then there was just a job opening. I saw they looked for somebody. I applied. I was lucky. They took me.
Wow.
And now I'm now helping member states on the bigger scale. But I still like my brachy heart is there.
Yes.
So this is like where I am totally enthusiastic about.
Yes.
And but I'm now helping on a different level, on the government level. I try also like change the mindset, change our field, and especially the medical physics are very underrepresented and also not recognized in a lot of other countries. And this is probably our main issue nowadays.
So you think this is the main issue for a lot of the countries?
A lot of the countries, yeah.
Yes.
Next to the education, of course.
Of course.
The education system is still very not advanced for medical physics.
Yeah.
But it's clear, it's not a business,
Yeah.
So usually people choose a field where there's more business, where they can make more money. A physicist usually is a passionate scientific person who doesn't do it for the, let's say, money. They do it for their, inspiration for their motivation, inner motivation.
So how can you convince people when you go from a country to a country where actual medical physicists and medical physics as a field is not recognized? How do you try to actually convince them to change this mindset?
Well, to change the mind is actually something very specific. So there are 3 ways how you change your mind. Yeah. So the first is with just logical arguments. Yeah? So there's a comparison, like when like riding an elephant. Yeah. So like you're the rider, you have your brain, you have your, let's say, clarity, your rational thinking. Yeah. So then the elephant is your emotional part. Yeah. So let's say if the elephant sees some nice fruit, they will go there. Even if you're the rider and say, no, we have to go this way, it doesn't really work. Yeah. On top, there's also the environment. As I said, like, you know, like this elephant is, I'm taking an elephant now because it's a heavy animal, right? Yeah. And it's moving in a direction depending on the environment. So in order to change, let's say, to make this elephant moving in a certain way, you have to change the environment. You have to have also aligned the rider, like the mindset, the logistics, and the heart of the elephant, like the emotion.
Yes, definitely.
So this is where you try to address on these multi-levels, helping to make them, of course, understand with logical arguments, but then you have to talk the language of emotion. And this is sometimes difficult because you have to address the other person, all these 3 levels, to make a change in their approach.
Did you see any actual improvements after years and years of going to a country to a different country? Did this actual trying to change the mindset, trying to improve, did it come a reality in some places?
As always, you have some success stories and some paybacks, but in general, it looks now much better than it was, let's say, 5 years ago. Yeah. Although still we have to do more. And I think this morning I also mentioned, like, if you want to go fast, you can go alone. But if you want to go really like far, you need to be together. And I think this, especially with societies, you know, it will help. Also, what I heard today, actually from your Minister of Health, so he is also very passionate, and he fully understands the importance of the medical physics, and this, like, addressing, as I said, like the rider, you know, the brain, the rational. So there is an understanding, but also you have to connect the emotion. That I'm always comparing. If you as a physicist are doing a mistake, you systematically mistreat a lot of patients, or you could harm a lot of patients. Let's say if a physician or a oncologist makes a mistake, he might harm or she might harm 1 patient because of a, let's say, wrong decision or wrong interpretation. Yeah? So we actually have a big responsibility.
Yes, we do.
Yeah? So, and this we have to emphasize, and this we have to bring to the people to understand the importance of our role.
Yes, great. I just want to go back to brachytherapy. Brachytherapy, is it a dying art, or is it still going on strong with all the advances we see with the external beam? Does it still have a role, you think? Do you think it will always have a role?
That's an interesting question. I always get this question, actually.
Yes.
And well, as long as we have cervical cancer, we probably need a proper boost. And there are some technologies they tried with stereotactic boosting to replace like the brachydose, especially in the parametrium. And by now, it was not really succeeded. There were some efforts that they could place like external beam and then trying to because you have to really precisely immobilize the target. With stereotactic technique to get it. So sometimes they had to insert applicators at the same time to give some part of brachytherapy, like higher dose, to the, let's say, cervix, and then to the parametrium boosting with stereotactic fields. But it's so much effort in comparison to a very simple technique using a radioactive source. Yeah? So this is one part where people try to replace brachy. Another one is with electronic brachytherapy. But again, you introduce more uncertainty than actually effect. So because the radiobiology gets very complicated, then all these miniaturized X-ray tubes, they are getting overheated. They don't deliver the same output as a radioactive source. So I think there's still a role. As long as we have cervical cancer, there is no way around treating with proper high-dose rate brachytherapy.
But don't you think that now the incidence of the cervical cancer has been going down since with the introduction of the vaccines, of the HPV vaccine and all of that?
That's yes, for sure. But on the other hand, people, how to say, the result of the vaccine, we will see probably 20, 50 years down the road, or maybe even later. And people are still, they're not aware of let's say, cancer. In some countries, they're not aware. They don't have access. So, and even if they have access, let's say, to the vaccine, they don't go. So we always have a population where they don't see any doctor, which we will then see in our clinics in need for treatment for cancer. And also, what I see is, because screening, of course, important. Like the early detection is very important. On the other hand, if you, that's also a burden. If you increase too much screening, you also have to then give you option to treat. So we already lack of treatment or access to treatment. So we have to be very carefully, like not over-diagnosing the patients, because then you also end up in a demand for treatment.
Yes. We just want to ask you a last question. What is your advice to anyone who's thinking to actually go into the clinical medical physics field? What should they focus on? Where do you think the future is going?
The future definitely goes into any kind of AI-assisted tools. And we here on the conference, on the MEFON conference, and it's interesting that there's, I think, not a single topic where they don't mention AI. Of course, it's a little bit no marketing, because it's all about automatization. It will help you to be more efficient. And I think as a medical physicist, our core competences are quality assurance. So I think there will be a strong or actually a big demand, a huge demand of quality assuring this algorithm. I mean, we also heard it today in some talks that the AI will exceed our human brain capacity. I think the AI is now doing better than us. But as I said, we still have this emotional, we have the relation, we connect to people. And this will not be replaced. So it will be a new way of living in a new kind of harmony with your robots and all your tools. But somebody has to make sure that first the data is correct and that what's coming out is actually quality assured.
Someone has to check the robot.
Someone has to check the robot.
So we still have jobs, I think.
We still have more jobs and more.
Thank you, Daniel.
You're welcome.
It's a pleasure to have you.
It's a pleasure to talk to you.
Thank
It's
you.
always nice to be here and surrounded by so nice people. And I'm happy to be here in
Thank you
Kuwait.
so much. It's our honor to have you. Thank you so much.